Good evening and welcome everyone to the 38th annual Reed Nesbit Urologic Society meeting, as well as our visiting professorship here at the University of Michigan. It's really a pleasure to see all of you here today, some of whom have come from all around the country, some from all around the world. And we're extraordinarily grateful for all of you taking the effort and time to be with us today. Before we get started, I just want to take a moment to acknowledge some of our sponsors who are helping with today's CME event, as well as with tomorrow's what I hope will be rather an exceptional get-together, both during the day as well as in the evening. First, I want to acknowledge our gold sponsor, LinxDX, our silver sponsors, Boston Scientific, Medtronic, Eurogen Pharmaceuticals, and our bronze sponsors, Axonics, Coloplast, Richard Wolf, and Telix. So a big round of applause for all of them. Thank you for your support. So without further ado, Dr. Blair, are you okay? All right, sorry. The door is sort of confusing, I know. But anyway, without further ado, it's my pleasure to introduce our visiting professor for this year, Dr. Peter J. Gilling. Dr. Gilling is professor of surgery at the University of Auckland, at Bay of Plenty Clinical Campus in Tauranga, New Zealand. I don't know if I pronounced that properly, Tauranga. Peter Gilling is a urologist with international reputation for BPH research in prostatic disease. He's currently head of the Bay of Plenty District Health Board Clinical Campus in Tauranga, New Zealand, and is a professor of surgery at the University of Auckland. He's also an assistant dean of the Faculty of Medicine there in Health Sciences, heading the academic site at Tauranga, the University of Auckland. He's a member of the executive management team there, and I think one would say probably the real movers and shakers of the healthcare system in New Zealand. For those of us in urology, we certainly know Peter is a household name in the management of benign prostatic enlargement, hyperplasia and enlargement. Peter is perhaps most well known for the introduction of HOLEP, for which we had our CME conference today, really beautifully put on by John Way and colleagues. Peter is, since that introduction in the mid-90s, late 90s, has gone on to do really enormous things in really the refinement of the HOLEP technique, and perhaps maybe more importantly, to go on to how to popularize it so that almost anyone can do it. And I think hence his presence with us today to really talk about his experience with the technique, share it with others, and allow us to ask him questions so that we can kind of further this technique, which has really turned out to be, I think, the gold standard for benign prostatic hyperplasia and lower urinary tract obstruction. It's really a pleasure to have Peter here. In addition to his many accolades, and you can Wikipedia him and Google him, he's also a pretty mean pickleball player. And so we may or may not have a game on Saturday after the game. And our residents may not be invited because I want to win. But anyway, Peter, welcome to the University of Michigan, and thank you so much for your time. So everybody, welcome, Peter.
Fantastic. But I won't be talking at all about HOLEP during this talk. I'll be talking about aquablation, which is another one of my interests from a research point of view. And I was thrilled to be invited to come to this meeting. I come from Christchurch. You can see that halfway down the South Island, those of you who've been to New Zealand. And it was interesting that in Christchurch, one of the books that was in the operating room in our organisation was, I've got the wrong one. Yeah, no, I'm just saying. I had a picture, and David carefully supplied it, and I put 2 copies of the thing, but it was Reed Nesbit's book on transurethral prostatectomy. And that was in our operating room when I was a resident. So I knew the name Reed Nesbit when I very first started urology in the late 80s. But anyway, so currently, so that's one slide that's missing. So that's a good start. Let's hope there are no others. So yeah, Tauranga, as you can see there, is just southeast of Auckland. And we are part of the University of Auckland clinical campus fraternity. There's 5 clinical campuses for Auckland Uni, and Tauranga is about the same size as Ann Arbor in terms of population, and the region that we're in. It's called the Bay of Plenty, and that's about the same size as Washington Tor, is that what it's called, in terms of population. So yeah, quite similar. And yes, we are the land of beautiful beaches and wonderful. And it's not just Lord of the Rings. That's all down south. All that rugged stuff and Mordor and all those places. So they're all. So yeah, this is Tauranga. So my current disclosure is relevant to this talk. First and foremost, Procept Biorobotics, it'll be their product that we'll be focusing on for most of this talk. And I was an investigator for them at a number of levels and still a consultant, and some other BPH-related disclosures. So it's an expensive business bringing a complex medical device to market, and this is one of the best studies I came across looking at the cost of these things. This was a couple of years ago in JAMA Network Open, and they did an analysis which suggested that to get for an FDA-approved product for a novel complex device, such as the ones that we've seen recently introduced into BPH, the average cost was $54 million US dollars to bring one of those to market. But if you account for the cost of failed studies and the cost of capital and put a bit of more of a business spin on it, it's actually $522 million. So you can see it's a very expensive business. And if you look here at the diagram from the paper, and if you look at the pivotal trial, you can see on average 57 months to complete this phase. On average, 565 patients required. The cost per patient, 54,332. And overall, they thought it cost about 31 million just to do the pivotal study for a complex medical device. And you can see those various percentages. They represent the chance of getting from one stage to the next stage. So, for example, for the pivotal study, to get from the feasibility study, to get out of that and to get into the pivotal study, 48% chance. But it rises to 76% chance as you get closer and closer to the PMA application, which is what the pivotal trials are all about, which is the pre-marketing approval, which is the bit that gets you the opportunity to start printing money. Now, how did we come about being involved in this trial? And this is a story in itself. This is a sort of a sub-story within the main story, because, I mean, Tauranga, New Zealand is, where's that? I mean, I know where it is. But the relationships are very important in this space. This company, Five Corners, were based in Sydney, and we had done some previous research with them, and they had offices in Sydney and Melbourne, and they have subsequently amalgamated with 5 other CROs, and they formed a company called Avania, which has American offices as well as a CRO. And what do CROs do? Well, they help companies that are starting up to sort out the clinical pathway to regulatory approval. They help them with all their preclinical testing, biocompatibility, sterility, and as you can see, cadaver studies, and then organise for them the first in human feasibility, safety and efficacy, and of course the pivotal studies. And then, if required, if they're lucky enough to get that far, the post-marketing approval side of things. And then when the studies are done, they help with the medical writing, data oversight, and of course monitoring and quality. And most importantly to the companies at that point is the regulatory stuff and reimbursement. It's all about reimbursement ultimately, and then they sell themselves, of course. But so what do they look for in an investigator? I mean, how do you get these opportunities? Well, you know, when they do their site inspections, they're looking for someone who's responsive, adaptable, honest, you hope. And they must have obviously relevant qualifications and experience in the area of the study. Reputation's important, helps if you're a thought leader, and then the patient and time to properly conduct the study. And the ability to do the study, and that really does involve research infrastructure. You've got to have the infrastructure already in place to be considered. We had one calling card, which was the fact that we'd already done one. We had done the pivotal study for Holmium prostatectomy. It was we did that in 1996 and over that until August 97, and it was unique because it was a single site. It was entirely offshore, and the company at the time, called Coherent Medical, got their 510K approval as the result of that study, and that really set us up because that made us a go-to place for a number of companies who wanted to do similar sorts of things further down the track. This also because the FDA don't care whether you ablate, resect or enucleate with the holmium laser, so this actually became the de facto FDA study for HOLEP some years later, and so they didn't have to reapply in any way, as we discovered, and I'll cover that shortly. So this company, Five Corners, they went to a meeting in Stanford in 2011. There's a Stanford biodesign course where a lot of our medical device entrepreneurs have started, and they presented a study in there on first-in-man device studies in Australia and New Zealand, just drumming up business for their business. And then the CEO of Procept, Nikolai Algieri, approached them to see if they could do some of the early work on their new device, which was aquablation, and they introduced us to them and them to us. And so I went over for a cadaver lab, which was a frightening thing. It was run by a Russian, and there was a room this size with 30 torso, no arms, no legs, no, and they're all draped. And so we went from one to the other doing these things. But at the same meeting, a couple of the real movers and shakers in the world of medical device, Rodney Perkins, ENT surgeon by trade, also a professor at Stanford, he set up a number of companies, but one you may have heard of is called so laser scope green light, and sold that for a fortune as MS, and also the name of Fred Moll. Now he's probably more interesting, a cardiothoracic surgeon who into this entrepreneurial stuff, and he set up a little company called Da Vinci. So, as you can imagine, these guys just go from success to success. Both these guys were on the board of Procept, and I met up with them, had dinner with them, and as a result of that, we shook hands and we got the opportunity to do the first cases with aquablation, which we promptly did in 2013. So what is aquablation? Why would we consider it? Well, it's the first of the new semi-automated techniques using robotic technology, and there are others coming for transurethral surgery. And there's a touchscreen interface that you can see there, and the surgeon directs the conformal treatment that's going to be ablated by the water jet. It was very interesting to me because I was more interested in tissue removal with the holmium resection and holmium enucleation. This was something that I could see could be maybe a pathway to the future of the transurethral surgery. And you can see the room set up there. There's two screens. There's one with the ultrasound image and one with the cystoscopic image, which is through the handpiece. And the whole point of the setup at the beginning of these cases is basically to align, make sure the truss and the handpiece were aligned and coplanar, and that takes probably a third of the actual procedure itself. You get a transverse image which shows you the water jet sweep and also the depth, and then you get the longitudinal image where you mark out the area in the longitudinal view with all the important landmarks such as the bladder neck external sphincter, and you can see the scope and the applicator. And we'll just see that this is just adjusting and bringing the water jet inside the capsule and then raising the depth. And you can see the sweep there is it's 135 degrees. So as we were talking this morning in the BPH course, that anterior tissue was left untreated, and that helps in some ways because continence is not an issue, and we'll talk about retrograde ejaculation further down the track. And then on the longitudinal view, you place the markers as I say, at the bladder neck, at the mid prostate. You can see the applicator up the top. That's the scope that's at the right hand end, and then you base the markers on those, plus what you can see of the anatomy of the transition zone. And then there's that down the left there. You can see all the markers, and on the right you can see all the various tasks. It's really quite intuitive in terms of the setup. And then away you go. You step on the pedal, and the water jet does its business following that treatment contour. Very easy to stop. You just take your foot off the pedal. It's quite safe. And then at the end of one sweep for a reasonable sized prostate might take 3 minutes. And usually you'd use 2 passes these days, probably sometimes 3. But still, the operating time might only be 5 minutes or something along those lines, so it's pretty quick. And then you irrigate the clot, do a bit of focal bladder neck cautery to make sure the hemostasis is satisfactory, and then return the patient to recovery. And here's a graphic showing what we're talking about approximately. With the animation, you can see below there's that's what you see while the thing's taking place, and you can also see in the cystoscopic image as the water jet comes towards you. And so getting back to the aquablation that we were faced with, this is the original device. This was the first-in-man study that we were looking at, and the first cases. The console, the screen, and the handpiece, and the arm attached to the console rather than attached to the bed, which it is now. This was the original applicator, and we can see that there's a green laser coming out of that, and that was one of the ways that they felt that hemostasis was going to be attained, which is through the water jet. A 4-watt green light laser was supposed to have sufficient power density to provide fantastic hemostasis, but it was completely worthless. So that was abandoned after about 3 cases. And you can see that this other screen for coagulation, you can see that the sweep that they were hoping to be able to achieve with the green light laser was circumferential, something like, see, they say 360 degrees. Well, obviously that wasn't going to happen with the design of the probe. So this was a prototype. The first publication was dog studies, eight beagles who were sacrificed at 6 weeks, and this was a sort of the proof of concept and the histology. And then came us doing these. This was the first in man study that was started in January 2013. It's interesting to note that they achieved FDA approval almost exactly 5 years after the first case, which is a world record for medical devices for BPH. So that was very slick. 15 patients treated, procedure time 48 minutes, hospital stay 1.8 days. Well, it was all very acceptable, and the usual 50% decline in IPSS. Interestingly, I really struggled to get this published. That's why it was so long after the cases were done. And I finally took it to a friend of mine, John Fitzpatrick, who many of you may know, who was at the time the editor of the BJU. And so I managed to twist his arm and get him to publish it. And interestingly, if you look at the number of citations, it has 130 already and climbing. And so there were a few people who would have been sad not to not to have got it after that, but that's the way of it, as we know with these, with the particularly first-in-man stuff. So then we went on to do a multi-centre Australasian study, ourselves, a site in Melbourne and a site in Perth. And this was the original multi-centre experience. There was also another cohort that were done in India that were published, and that provided the pivotal clinical data for the submission. So pivotal trials. What are pivotal trials? Well, the pivotal trial concept is an FDA construct. They feel that there are three phases. There's the exploratory phase, which is all the basic biocompatibility stuff. There's the pivotal phase where you collect all the clinical evidence, and then there's the post-marketing, post-approval phase. So I'll focus naturally on the pivotal trials because that's what, and we'll go through the water study, which is the pivotal trial for aquablation. But it's basically the clinical study that's designed to collect the primary evidence of safety and effectiveness to support their application. And this is only after sufficient evidence of device safety and function is available, and that's where we came in terms of those early clinical studies. And a proper pivotal study needs to be designed properly to minimise error and bias, and we'll talk about those shortly, and also to facilitate objective assessment by the FDA of the investigational device. So it is pivotal in many ways. You pivot, I suppose, between feasibility and post-marketing approval, but it is you know, everybody knows what you're talking about when you're talking about a pivotal trial. It's the one that gets you the approval. And this is the new guidance for BPH clinical trials. There was one previously, 10 years before that, and that was the one that we used when designing the pivotal trial for aquablation, of course, because that was already long gone by the time this was produced. But it's an excellent document for people who are interested in BPH and BPH studies. And I think yesterday we talked about it at the music brainstorming session. I'm not quite sure who was there, but this is a good worksheet to see what it is that you should be monitoring and what you should be measuring in a BPH study. So the water study. This was the pivotal study that we had earned. And so I was the Klaus Roborn. Now, I'm not sure how many of you know Klaus. He's the chairman currently in Dallas. But interestingly, I did a 2-year fellowship in Southwestern in Dallas in 1991 and 1992. And Klaus and I were fellows. I was the junior fellow and he was the senior fellow and hardly ever spoke to me. So it was quite good. For those of you who know him, you might appreciate that. But anyway, he went on to greater things and I went back to New Zealand. But anyway, so it's sort of ironic, but here we are. So what are the considerations for a pivotal trial? Well, as far as the FDA is concerned, you've got to have multiple clinical sites. And the reasons for that, if there are any statisticians in the audience, are obvious. They've got to be believed that the results that they get are reproducible and particularly representative of the general patient population. You've got to form a clear study objective because that identifies what control you might need, the primary endpoints, what follow-up you need, and also the statistical hypothesis. And of course, it's got to minimise bias. Bias is one of the main issues which leading to false results. So what is bias? Well, that's a characteristic of either the investigator, the study population, or in the conduct of the study that interferes in a systematic way with the ability to measure a variable accurately. So bias is very important, and this is the randomised controlled trial. This is why we do them. So it's to minimise bias and control for confounding factors, both known and unknown. So the randomised controlled trial across multiple clinical sites is what the FDA expect for all new devices. So this is out of their document. These are the different sources of bias that the FDA identify for BPH trials. Selection bias and the mitigations down there on the right side, randomisation being the big one, but also having objective diagnostic and outcome measures and so on. Investigator bias, when the investigator consciously or subconsciously favours one group over another, would be easy to do. Blinding is very important. So a single or double-blind trial with even evaluators being blinded is ideal in that regard. Evaluator bias, once again, blinding. We'll talk a little bit about the placebo or sham effect and having a sham arm in terms of your control shortly, but randomisation, once again, helps you eliminate that effect, and you've got to have a plan for all your missing data. So, multi-centre study, these were the sites. Across the US, that was the bulk of the patients, and you can see the number of patients randomised from each site on the right there. And yeah, we enrolled 20 from our site. I'm not sure if Klaus enrolled any, did he? Oh yeah, he did, 6. So we beat him. Yeah, so as far as the pivotal trial goes, the control, you've got to put a lot of thought into that and come up with an appropriate one. You'll probably see that most of the recent BPH treatments that have come on the market, and I'm thinking iTind, I'm thinking Resume, I'm thinking Urolift, all of them got away with a sham arm. But aquablation had to have something that removed tissue. So TURP is always what the FDA would be looking for ideally. You'd have to have a damn good reason not to use TURP as your control. We talked about blinding and its value in eliminating bias. And also you have to put quite some thought into the study endpoints, both primary and secondary. A little bit of a sideline about the placebo effect and the sham arms. So the placebo effect, there's a number of sources. The patient's expectation of benefit is a source. Regression to the mean, which is where if you've got an outlying or an extreme variable, the next variable is going to be closer to the average. The so-called showering of of attention, the Hawthorne effect, comes from just down the road. There was a place called Hawthorne Works, which is close to Chicago, and they were doing a study looking at ways that they could improve productivity in their workers. And they found that just by observing them, their productivity improved. And it became known as the Hawthorne effect, but it's just something that's got to be allowed for and is thought to be one of the sources of the placebo effect. Both objective and subjective endpoints are subject to the placebo effect, so you can't assume anything for any of these endpoints, and that's why you randomise and you blind. And the FDA say that the sponsor should consider checking in with the subject and the physician who's blinded as to what arm they thought they were in. And with the water study, we did that at every appointment, at every site, and found no evidence that they knew what was going on. And obviously, there's an enhanced placebo effect for devices when compared to drugs. And Chuck Welliver from Albany, who will be known to many of you, with Kevin McVeary, did this very nice study, just looking at the size of the effect in the sham arms of a range of randomised controlled studies for BPH surgeries, and showed that in the sham arm, for the IPSS score, at 3 months, you got a 27% decrease, which is appreciable by the patient. Anything over 3 is thought to be appreciable, and then a 16% increase in the flow just by being in the sham arm. So it is a thing. Anyway, back to the study. 275 men. There's our inclusion and exclusion criteria, which define our study population. Fairly standard stuff. I think you'll find that all these trials have pretty similar values in that regard. So 181 randomised. Randomised 2-to-1. 2-to-1's very common for medical devices. Statisticians don't like it, but it does give you twice as many people in the active arm, which can help with recruitment, because people think that it's that they've got a better chance of getting the active treatment. But it also gives you more people to help understand and help the FDA understand what your device does, how it works, and how safe it is. So it's pretty much all the recent trials are all 2-to-1 in terms of the randomisation. So 116 versus 65, and the original idea was to follow them through for 3 years. So getting down to the primary endpoints, these are supposed to be clinical measures that characterise the safety and effectiveness of the device. They're supposed to be objective, repeatable, and meaningful and relevant, yada, 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 but then they go on to say it's got to be the AUA score. There's no other choice. And you've got to compare that to baseline. So you don't have to think about endpoints, because the FDA tells you there's only one that's acceptable. And they expect to see an improvement of at least 30% in that following device therapy. So that's primary endpoints of effectiveness all sorted and mandated. After all those lofty statements about, and we all know how unreliable the IPSS score can be in many circumstances. As far as safety, this is always pretty standard. It's based on the incidence and severity of adverse events and their relatedness to the device or procedure. And you compare the frequency of those with the control arm, which is the usual way of doing it. And this study was no different. So what were the endpoints? There was a 3-month safety endpoint for the water study and a 6-month efficacy endpoint. The 3-month safety endpoint was the proportion of patients who had events, and they split that into grade 1 events, because this is what a lot of these companies are really looking for, which is all to do with retrograde ejaculation. And we can see persistent grade 1 being separated out from the serious ones, which are grade 2 or higher, and they were compared between the two groups. The 6-month efficacy endpoint was, as we've just said, the change in IPSS score of 6 months. So both were tested for inferiority, and then if they were found to be non-inferior, then there were tests for superiority done, and of course and properly powered. Secondary endpoints are a little bit more interesting, but they still just give you a list that they expect you to measure. They don't. There's all these advantages of the endpoints. They give you a lot more information about how the treatment works and gives you a better understanding of the mechanism and the primary endpoints. And it also allows you to consider sub-hypotheses and exploratory analyses, and also helps to support further device performance claims that you might want to do further down the track if you're the company involved. And so for BPH trials, these are the things that they expect to see: prostate volume, flow, residual volume, and quality of life, return to normal activities, and normal symptom and symptom severity they've added since the one 10 years before. But of course, sexual function and dysfunction are very important. Study duration, they want to see a year to assure stability of the treatment effect, and expect annual follow-up. And the expectation is that your pre-market study during the follow-up will turn into a post-approval study with those extra time points. The statistical hypothesis needs to be considered, and the selection and exclusion criteria to help define your population, which we've already mentioned. So yes, the patients were randomised, TURP versus aquablation, and you can see virtually all patients made it through to the 12 months, so the data was pretty robust in that way. And here are the baseline characteristics. Nothing particularly interesting there, other than that there was no statistical difference between the two, as you would expect, with randomisation with the proper powering of the study. This was the interesting bit that the company really was pleased to see, which is the primary safety, showing that 42% events versus 26% superior for 26%, so less events for aquablation, statistically significant. But if you look at that bottom table, those graphs on the bottom right, we can see that this is all due to these CD1P events, which are the incontinence, erectile dysfunction, and ejaculatory dysfunction. And really only one of those, which is ejaculatory dysfunction, almost entirely due to retrograde ejaculation. So the ones that matter are the ones on the right, for which there is no statistically significant difference. So no difference in patient primary safety, but that's not what the paper said. In terms of the primary efficacy endpoint, at 6 months, there we can see it, no difference between the two of them. For IPSS scores, 22.9 down to 5.9, which is what you would expect, and what you also see in the TURP group. The other thing on this slide is the mention of the learning curve. 14 out of 17 sites starting this trial had no prior aquablation experience, so there's really no learning curve to speak of, and those of us in the audience who are doing these could probably testify to that, Laurie. Yeah, the learning curve is all in the setup. Yeah, it's not the procedure itself.
I think the learning curve is in how you handle it after the aquablation. I think that's the piece that is
Yes.
But I agree with you.
Yeah.
The setup, the defining how you're going to create your bladder neck and all that. That's
Yeah.
fairly standard, I think.
Yeah. And here's the 12-month data. Absolutely no difference between the two treatments at 1 year, as you would expect. The change scores for IPSS and quality of life, and here we see the flow rate there's no statistically significant difference between the two treatments at the 6-month mark, nor for post-void residual. So these are some of our secondary endpoints. And these have been followed out to 5 years, and as you can see, both are durable, and data was produced as it always is with these studies at 1 year, 2 years, 3, 4, 5 years. There's 5 publications there with only little tweaks each time. We'll talk about that shortly. And here we see them graphically, no difference between the two treatments year on year out to 5 years. And the retreatment rates, either medical or surgical or starting a new BPH drug, 6% versus 12%, no significant difference between the two. So that's the water study. I'll just talk briefly about the water 2 study, which was an observational cohort study which the company sponsored entirely in the US, and it followed on. You can see that the water study was 30 to 80 grams, and this was 80 to 150. All the parameters measured were the same in both arms, and they were quite rigorously followed. And we also took part in the open water study, which was basically a real-world study, which really just validated the safety and efficacy in all comers. But in the water 2 study, which is the large prostate study, 114 men, same inclusion and exclusion criteria apart from the size, and 101 men were treated, and they were supposedly followed up for 1 year, but they got the 2-year, 3-year, 4-year, 5-year treatment as well. We can see the differences, symptomatic, large prostates, on average 107 grams, and 83% had median lobes. And we can see here what we were talking about before, the number of passes. 33% of these large prostates had just one pass, 56%, there was 2 passes, which basically means that the water jet retreats the area 2 times or 3 times. And we can see 3 or more passes and 10%. So we can see that the aquabation time was only 8 minutes. But if you look at truss insertion to catheter placement, 55 minutes. So it's what we were just mentioning before about where the learning curve is really, is in terms of aligning the patient and the device and just getting things right. But average of 1.8 passes in this large prostate group. And so, and in this study, 9 of the 16 sites had no prior experience. So it's not bad really if you can treat a 100-gram prostate with a brand new treatment that without any obvious deleterious effects and good results. So that is one of their calling cards, is the fact that there's no learning curve. I'll talk a little bit about hemostasis because this has been the one sort of Achilles heel of the procedure. And these are the various ways we've approached hemostasis. Originally, the company felt that it miraculously was going to be hemostatic just by itself. Because they did a whole lot of prostates in India. And they must have very small avascular prostates because they got away just with the catheter and I think it was 30 or 40 patients that they treated. But they did for the first few cases try this low-powered laser, the green light laser, which didn't work. And so really electrocautery has been the mainstay. There was a period there where catheter traction was the preferred way of doing it. We're trying to avoid electrocautery at any cost so that there was no frequency in dysuria. Originally it was a saline bag hanging over the end of the bed for 2 hours, and then they developed this ingenious little traction device that you can see there on the left. And the reason I think this is important is because if you look at the way they managed patients post-operatively in the large prostate study, 98% of them had bladder neck traction, and 100% of procedures were performed without cautery. So they were going through the non-cautery phase at that stage, which of course we've reverted to using cautery since this study. But look at the length of traction. Who knew you could leave the traction on for 18 hours on average? Yeah, but it was very common for them to be left overnight with catheter traction, and it just proved what's possible with catheter traction, and this is using that device in every case. But here's the downside of that: 10 transfusions, 6 prior to discharge, 2 in the first 2 weeks, and another 2 within that first month. So it wasn't a very smart move doing that, but they were adamant that there was not to be any cautery used so that the patients didn't get dysuria and so forth. Another benefit, of course, of pivotal trials is you get an enormous amount of publications out of it. So I've had 29 so far, and 6 of them is the new data from the pivotal study. 9 is comparing the pivotal study with other studies and various other subsets, some review papers, and of course those early ones. But yeah, that is definitely one of the if you're into collecting publications, be part of a pivotal trial. And this is the most recent one, and this gives you an idea of how you can slice and dice these forever. This is the water versus the water 2 study 5-year update. So there is a 5-year water paper, there's a 5-year water 2 paper, and then you do a comparative one, and it winds up in BJUI Compass. And you can see the galaxy of stars there. I'm sure a lot of you will know these people. Yeah, they just keep piling up, these publications. And this was the data comparing the Water 1 and Water 2 study. And basically it does show that there is up to 150 grams, there is size independence. There's no difference between treating a 60-gram gland and a 140-gram gland in terms of the ultimate outcome, apart from the 10 transfusions. So anyway, this was done through COVID. and as you can see, at 5 years, only 50% of the water patients and 59% of the water 2 patients were accessible. But the freedom from retreatment was 94% for surgical treatments and 96% for medical treatments, so durable, and 33% reduction across the board at 5 years. So they rightly concluded that it seems to be up to 150 grams seems to be durable. So there we are in summary. Aquablation received FDA approval in 2017, and there is pivotal trial evidence can be applied to many publications, and being involved in these does lead to relationships and future studies and so forth. And they have produced a new platform which came out last month called Helios, and that has more AI in terms of the setup. It has an integrated cystoscope into the handpiece, which is all fully disposable. And yeah, what was the other thing? Oh, integrated ultrasound into the actual console. So it looks pretty flash, so that's the next one coming. But yeah, so for those of you who've just bought one of the old ones, bad luck. So that's the talk. And I did have a slide of the Helios in that other set, along with that that book on transurethral prostatectomy from Dr. Nesbit, which was a perfect start to the talk in that way. But anyway, thanks for that. Is it a question thing?
Yes, absolutely.
Good.
A couple minutes for questions. And then just honestly, thank you for everyone for coming. If you do an ID badge, I do need back like an official one like this, the ones you can keep. And we again to 7:30. But here, who has a question? I've got the mic for you.
Sure.
Oh, go ahead. Go ahead. Yeah, thank you, Dr. Gilling. Great presentation. So this may be an obvious question, but why does the technology not treat the anterior tissue? Was that an intentional decision, or was it a design limitation of the instrument?
Yeah, the thing about it is the water jet penetrates a maximum of, I think, 4 centimetres. So you can see that if the sweep was any more than about 135 degrees, you'd be out of the capsule as soon as you got above about 8 o'clock. And yeah, so yeah, it's basically, I mean, this is serious stuff. These water jets, it's up to 8,000 psi. And you've all seen pictures of, water jets cutting steel and cutting wood and so forth. I mean, you've got to be pretty careful with the way you place your water jet and so forth. But if you could, the speed at which it moves, I mean, you wouldn't be able to sort of turn it off when it got up to about here, or because it's moving so fast. Yeah, I think it's basically just a limitation of the technology. But I mean, if it's worth overcoming, they'll do it. Yeah.
So for the original water study, were patients actually blinded to their group, or they knew they were?
Patients were blinded, and the evaluator was blinded.
Okay, so then in the follow-up up to 5 years, when were they unblinded? When were they unblinded? Did they, so during the follow-up, were they blinded for that whole period they didn't know?
They're supposed to be. They were at our side.
Okay.
Yeah. They all, and as I say, at all those time points, they filled out those blinding questionnaires, and there was no signs of contamination noted. Yeah.
That was a great talk. My only question is, as someone who kind of straddles the line between inventing something like anatomic enucleation of the prostate and being a part of a pivotal trial for something like aquablation, which is, certainly coming on strong in the United States, how do you choose patients in your practice for either of the techniques? And if you get patients ask you all the time, right? Like, hey, doc, if your dad needed this operation, what would you choose? Like, where do you stand on that?
Well, for me, to get aquablation, they've got to enrol in one of my trials. There's no other way because I use HOLEP for my normal clinical work. So it's and we've got another study about to start on clinically localized prostate cancer for transition zone lesions. So they've already we're just going through ethics now, and they've got a few sites already lined up. So that'll be the next opportunity for people to have aquablation at our site. But obviously, as we can see, there's been thousands of patients done around the world, and there are plenty of places you can get it if you're prepared to travel. But we're the only unit currently in Australasia, which is Australia and New Zealand. So yeah, there's not too many in the Southern Hemisphere.
So, Dr. Gilling, thank you. Really interesting to learn about the process of these trials. You had a slide early on that talked about the characteristics of the principal investigator that facilitated successful trials, but we all work within institutions. So could you talk a little bit about what are the characteristics of the institution to help make that a place, an environment, a culture where clinical trials can be done and you can easily enroll your patients in clinical trials?
Well, I would imagine that for you guys, it'll be easy for you. It's really tough for small units like ours to attract the big players, whereas you might remember the very last thing on the list there was appropriate facilities and support, which basically means you've got to have a tribe of research nurses and data collectors, and you've got to have, you've got to have all the things that a big institution has, and that I would imagine that would make you much more attractive because you're obviously already steeped in research in this place, particularly with the #1 in NHI grants and a few other things. You'd be a very attractive site, I would imagine. I think it puts you at a great advantage. Yeah. And I'm not really bitter and twisted about missing out on all these good studies because we're too small and too far away.
If there's not, I just will reflect, and I'm curious for what other folks in the room from Michigan might say. You might be surprised actually how difficult it is to do clinical trials at Michigan. And so, it's interesting to me to hear kind of your assumption about how it would be smooth here. I would say our experience is that being a big institution actually makes it more difficult with the infrastructure, the red tape, exactly. And so I was curious, what helped facilitate at your institution, your involvement and your ongoing involvement in these trials? Maybe being smaller is better.
Our only problem in that regard is that because there's not much research of this type being done in our institution, they don't quite know how to deal with us. They don't know, all of a sudden there's a whole lot of committees that get involved and people trying to look for reasons why you can't do it. So yeah, but it is a thing.
I'd say in BPH and device, where a lot of these startups don't have a lot of money, the problem is with a lot of the American organizations and facilities are overhead. So the biggest thing when you talk about what is a facility that's attractive. So Brigham right now charges 65%. So that's enormous, right? Like it's a very high amount. For these smaller companies, like a lot of the prostatic stents that are coming out, that's too much. They don't have investors that can give you that much money. At the VA in Boston, we're the most expensive VA in the country, but we're at 35%. So while it feels like a lot for other VAs, what makes you appealing as an institution is if your overhead is kept down to the lowest amount so that these smaller device companies, these startups can afford to pay that. So I think here in the US and BPH device anyway, I can't speak so much for PROCEPT, but at least in the stents coming out, there are a lot of actually small practices because they don't have that overhead. So there are a lot of smaller groups as long as you can meet your enrollment. These companies that don't have a huge investment they can put behind it, they're actually quite happy to work with small group practices that aren't going to charge them all this extra money. So cancer is a whole other thing, but in device, that's what we do, especially in BPH device. These are small studies. They're only looking to enroll like a couple of hundred people. And it's expensive to put all the devices around. I mean, at least with the water studies, you had to put the actual machine there. The stents are, the prostatic stents are different, right? Because they're all peel packs and disposable scopes. use it.
And it's a $500,000 machine, and they've conveniently forgotten about it and left us with it. And we've got probably 20 free devices.
Handpieces.
Yeah, so I might just be using them just casually sometime. Yeah, so maybe that patient can get treated.
All right, we'll leave it at that. Thank you.